Good afternoon, everybody. Welcome to this MS Academy webinar entitled Putting the Policy into Practice. My name is Jeremy Hobart. I'm a neurologist based in Plymouth, and I'm joined by three speakers. Georgina Carr, who's well known to everybody, is the CEO of the Neurological Alliance. Ian Pomeroy, the consultant neurologist at the Walton. Perhaps less well known to people, Jennifer Duffy, who's the Operations Service Manager at the Walton Centre. I'd like to start by thanking the sponsors, Roche, for supporting this webinar, and also to announce that the report entitled NHS Reset and Reform, that pamphlet is available, and there's a web link in the chat that you can access that by. I'd like you all to give an opportunity to ask questions. You can do this through the Q&A function. And so I've been asked just to say a small amount about why we should engage with new systems. And I'm going to leave the explanation of integrated care systems to Georgina, but simply to say that as of April 2021, there should be some 40 plus integrated care systems in the UK, which will be the future of healthcare. As of April 2022, these become legal entities. Why should we engage with them? Because they will be holding the budgets and the power, and because I think it's fair to say that the Raising the Bar for MS audit has demonstrated quite categorically that the impact that we have had as MS teams locally in terms of service change have been very, very limited. So on that note, I will hand over to Georgina Carr, the CEO of the Neurological Alliance.
So thank you ever so much for having me back to the Academy. Really pleased to be here. And I've got rather a long title for my presentation, but I think it basically means why is setting out what good care ought to look like really important in improving integrated care and experience and outcome associated with that. Just in case you're not aware of the Neurological Alliance, we're a coalition of around 80 organisations, including the Academy, who most recently joined us, all committed to improving treatment, care and support across England. So just to start a little bit on the policy and political context of all of this, I don't need to tell you that obviously coronavirus is very much kind of dominating political discourse at the moment, and that's having a number of impacts. One, of course, is around the vaccination rollout, which continues to move at pace. We're also seeing in that rollout some inequities in access and uptake of vaccination as well, and that's going to have an impact on recovery in the longer term. We've seen huge impacts of the shielding programme, not least of all in terms of laying bare the challenges around the data that we hold in order to identify those at the time who are the most kind of clinically extremely vulnerable, and suggested that real improvements were needed to be made there. Seen massive impacts on mental health, both on the health and social care workforce, but also, of course, people with neurological conditions. We've actually just done a survey in February of just a snapshot of around 250 people with neurological conditions, and around 58% of people said they felt either anxious and or hopeless, and so a kind of coherent recovery to COVID-19 is absolutely going to put ensuring people's mental health needs are supported front and centre. And more broadly, we are seeing an economic downturn, and that in itself poses some problems, both in terms of the spending available in future for kind of service recovery, and for things like social care, which we know has been chronically underfunded for an awfully long time. It's also having its impact on the voluntary sector as well. People aren't able to give as much as they were previously. People aren't going out to charity shops either, as they've been closed, and sponsorship and so on is down as events have been cancelled. And of course, within all of this, it's the perfect time to have some of the kind of most far-reaching NHS legislative reforms that there have been for around about a decade. And NHS England DHSE set out its approach in its white paper in February of this year, which largely, as Jeremy was talking about, talks about the establishment of integrated care systems, which are going to be legislated against, likely from the Queen's speech in May. And that in itself has a number of implications potentially for MS and how it's services and how they're commissioned. It's also important to note that there's an awful lot of transformation going on alongside that. So Public Health England is in the process of being abolished. So that's likely to no longer exist as of October this year. NHSX, which is a mere around 24 months old, is also being abolished and subsumed into NHS England. And actually they were doing an awful lot around digital transformation in particular and integration of care. So lots changing in terms of the policy context. So why should all this matter to us? I think the focus on integration within the white paper is going to be absolutely pivotal for service improvement. It talks about bringing relevant bodies together locally, for example, acute trusts, local authorities, etc., through various local ICS boards to look at setting out kind of service improvement initiatives and essentially services that will meet the needs of the population within that area. It also talks a lot about how data, digital and technology should be better used in the system to enhance health and care outcomes. And there'll be a data and intelligence strategy coming out from DHSC in the coming months. And I think that gives us a lot of food for thought, particularly perhaps within MS. And specifically around D&T commissioning, that could well be devolved as a national responsibility. So at the moment it sits with specialised commissioning, and if devolved, there is a risk that could heighten regional and warranted variation in terms of the D&Ts that are available at a local level, although that hasn't been agreed just yet, and the thresholds in terms of what's going to be commissioned where haven't been decided yet. So it's all to play for at the moment. It's fair to say at the moment it's a really, really complex commissioning environment. And so on the left, this is a lovely diagram that the MS Trust developed a couple of years ago through its MS Forward View, which just highlighted the various kind of sources of funding for the different services that a person with MS might need at any one point in their lives. So it just shows you just how complex a situation it is, in England at least. On the right, you can see that actually the total cost of neurology actually differs markedly between regions as well. So the cost per head is highly variable from different between different centres across England. And this is derived from the Getting It Right First Time programme methodology report, which was published a couple of years ago. And actually the full report will be out any day now. And I'm sure that will show significant unwarranted variation. And in terms of what we're hearing, of course, from people with neurological conditions, we asked 10,000 people prior to the pandemic their experience of services, and what they're not experiencing by and large is integrated care. And just to highlight one in particular, you'll see on the bottom right, 28% of people disagreed that information about their treatment and condition is effectively passed between the different people who care for them, which is, in an integrated system, you'd certainly want that statistic to improve. We're also seeing huge regional variation in terms of experience. This is just one example that we found. So that just shows you on the left that actually, in some areas of the country, just around 35% of people feel that their needs are being met around access to a specialist nurse. And it goes way up to around 60% in those areas where performing perhaps a bit better. But of course, we would want everybody to have access to a specialist nurse when they need to, not least for an MS, when you know the difference that support can make. And people with neurological conditions more broadly tell us time and time again about kind of the challenges in terms of referrals and essentially feeling like their care isn't coordinated at a local level, and that has a real impact on their experience and ultimately their outcomes as well. So all of that is kind of the context in which we're working in, and so the why really is that we know that the timely responsive neuro treatment care and support can improve quality of life, but all too often that's just not taking place. And we feel that setting out optimum pathways in MS and other neurological conditions could well help. And we're not the only ones that are saying that, just to be clear. The WHO have just said that in their draft action plan on neurological conditions. As you can see there, they would like to see evidence-based pathways of coordinated health and social services. The Scottish Government have set out a commitment to develop good referral pathways for neurological conditions in their action plan for neuro. And just yesterday, NHS England felt that optimum clinical pathways are going to be central to managing the elective care backlog as well. So again, there's very much a need within the system, and as a community, our challenge is to kind of respond to that. And of course, we have most recently the collaborative work that's been undertaken through the NHS Reset and Reform report by the Academy, which really does put developing pathways front and centre. So how are we doing that? So through the National Neuroscience Advisory Group, which is a multidisciplinary group that I co-chair alongside Adrian Williams, who is a consultant neurologist based in Birmingham. He also chairs the Neuroscience Clinical Reference Group within HSE, have been working kind of across the community to develop a suite of optimum pathways, which are illustrated here. And MS was actually one of the forerunners in that when it was started to be developed in, I think it was around about 2019 that we started to come together to discuss that pathway. But what's hopefully clear is that actually we've got an awful lot of neuroscience covered in terms of those pathways that we are developing. And then on top of that, we're developing what we kind of call horizontal pathways, which essentially pull out those common themes across the kind of condition-specific ones around rehabilitation, genetics, mental health, transition between paediatrics and adult services, and dementia as well. So as I say, MS very much is a forerunner, and the optimum pathway itself is contained within the report and was the result of many meetings between a good, kind of well-represented multidisciplinary group a couple of years ago. This was out for consultation last year as well. There weren't any major issues with it, although we're just collating the comments received at the moment, and the final one will be published by the end of May, where we'll also be hosting a series of kind of communications events around that as well. But it is there, and it's in the Reset report if you want to take a closer look. So now that we do have the optimum pathway, what's needed now? I'd urge you please to use it with colleagues in your region to kind of critically assess your own service. And I think Dr. Pomeroy is going to talk about his own experiences of doing that in particular. I'd really, really urge you to work really closely with people with MS, with people with neurological conditions in terms of assessing service provision in your region. We've actually just done a series of focus groups with people with FND around the functional neurological disorder pathway, and that's been really, really helpful in terms of understanding from them what good care looks like. And so I'd like to see that level of co-production across the pathways that are being developed, really. I think collectively, now that we've started to set out what good care looks like, we need to understand what outcomes and experience are associated with that care, and ultimately set about how we would understand, I guess, those outcomes and experience and the extent to which services are meeting those. And really, there is a fair amount of data that is generated, and we don't always use it in the most effective and efficient way possible. I think that's particularly true perhaps within MS, and if we're able to kind of align some of those initiatives a little bit more, then I would have thought that we would be able to kind of come to a better version of the truth, essentially, in terms of the gaps and where improvement is most needed. Should also say that I think health economics in particular is going to be a really, really critical part of that. We've already had indications from ICS leads that actually we need to kind of bolster our health economics case in particular, and I'm aware of a couple of pieces of work around that in MS specifically. Health inequalities have had a really, they've been laid bare in COVID-19. That's undoubtedly true, and I think they need to be at the heart of any kind of pathway work you might be doing in your region, reaching out to kind of a diverse group of people with neurological conditions to understand their needs and experiences with your service, and is going to be absolutely critical. And of course, innovations like remote consultations, etc., making sure that they work for everybody, not just those perhaps with higher levels of digital literacy or the space for a remote consultation or whatever. We need to be making sure that these innovations work for everybody. I've talked about defining good outcomes and experience, and there is a national programme of work that's looking at that across neuro at the moment. And then finally, I just urge you to share good practice. So if you are reviewing the pathway in your local area, you know, there are a number of networks that you can use to do that. And here's just a list of kind of some of the resources that are available to you. And then finally, I would say that I'm also really interested if you are using these tools, etc., because we don't want them to just sit on a shelf. We really do want them to be used. So please do reach out to me if you have any queries or questions, or indeed if you've just got some good practice you want to share. So thank you very much.
Thank you, Georgina. It's excellent. We'll come to the question and answers at the end, if that's okay. So we're going to bring Jenny's presentation forward, and which is on the GIRFT recommendations. But I'd like you to, before you start, Jen, can you explain what an operations service manager is and how they differ from a service line manager and the many strata of managerial positions that exist within the healthcare?
I can. Thank you, Jeremy. My actual role is divisional manager for the neurology services. So I sit underneath the divisional director for neurology. So it's implementing the recommendations from numerous different organisations and reports and building services in line with those recommendations. The operational managers sit underneath me in terms of making sure what we've agreed is happening and taking place within the organisation. So thank you and good afternoon. For those that I've not met before, as I've just mentioned, my name's Jen Duffy and I'm the Divisional Manager for Neurology at the Walton Centre. Thank you for allowing me to talk to you today about integration and system working and how GIRFT is supporting this work at the Walton Centre. So what does neurology look like across the UK? There are a small number of neuroscience centres. There are a similar small number of neurology centres with inpatient services. We have a large number of DGHs, district general hospitals, with small in-house neurology service, but without inpatient facilities. We have also a large number of district general hospitals with no in-house neurology at all, and they rely on visitor neurology services like what the Walton Centre provides to support their needs. So neurology itself is the only specialist hospital trust in the UK dedicated to providing comprehensive neurology. We serve a catchment area of 3.5 million people across Mersey, Cheshire, Lancs, Greater Manchester, the Isle of Man, North Wales and now beyond. We have service partnerships with 14 district general hospitals across the areas we serve. So what does that actually mean in terms of what we do for our district general hospitals? We provide weekly outpatient clinics on the hospital site, on average 3 to 4, which are led and delivered by the consultants per week, with 2 to 3 that are supported by the nurse specialists. And we also provide between 3 and 4 ward consultation sessions per week. And this allows people who have been admitted to the district general hospital with a neurological sign, symptom or condition to be reviewed by the visiting neurologist, who can provide support, advice and input into the care of that person. So as many of you know, Getting It Right First Time, GIRFT as it's commonly known, is a national programme designed to improve medical care within the NHS. GIRFT is delivered in partnership with NHS E&I. And what GIRFT allows you to do is see in depth where you are compared to your own area and the region and that of others, and what we're doing well and what is okay and is okay enough, and what we can do to improve or what we need to do to adjust. So following our deep dive GIRFT review, it did highlight some good practice, which is that we've got a very highly effective and efficient outpatient model. We've got very effective and embedded clinical pathways, noting specifically the headache and post-seizure pathway. It also noted our effective and efficient integrated neurology nurse service, all of which GIRFT recommended we should share with other neurology providers with a view for them to embed similar services within their own model of care. GIFT obviously did highlight some areas of focus, specifically our responsiveness to the acute element of our model. GIFT recommended that we specifically look at the possibility of introducing neurology wards at each of our partner hospitals, the introduction of ambulatory care at each hospital frequently, and rapid access to support from neurology for patients that are presenting to an emergency department. How can they quickly get access to our support if it's needed? Delivery of procedure-based outpatients closer to people's homes was also recommended. So what we've done so far with this information, and some of this was already in development, we're exploring opportunities to cohort neurology patients into one area within each DGH site. And this allows the opportunity to work with the DGH clinical teams and colleagues to develop their skills and knowledge to provide high-class neurology care. We have introduced weekly ambulatory clinics across 3 of our partner sites with a rollout plan developed. And excitingly, we implemented in mid-February a rapid access to neurology assessment service for our ED and MAU colleagues across our partner hospitals. This service allows dedicated access to neurology registrar or consultant Monday to Friday, 9 to 5 p.m. Part of this service, we offer the opportunity for the transfer of an appropriate patient into the RANA assessment area, which is led by our consultant who has ring-fenced time for this level of support and also access to several diagnostics, including MRIs and CTs and also neurophysiology. And it's interesting and exciting to know that since the RANA, Rapid Access Neurology Assessment, was introduced, we're already seeing quite powerful benefits emerging. We've had the feedback that people are seen in the most appropriate, by the most appropriate person in the most appropriate environment. We're seeing that people are avoidance of longer than necessary hospital stays, avoidance of unnecessary tests and procedures, and access to the right tests at the right time, and rapid diagnosis and treatment being delivered. We do need to continue to evaluate, it's only very new, and evidence how effective it is and how we are, and what we're already doing is building outcome measures to be able to do this. And we've already started looking at how this could be expanded and developed with potential an inpatient area within the Walton Centre site. We also must, it was mentioned earlier, that we must implement the use of technology and continue to do so for both people who are admitted and for our outpatient services as well. But it is important to note that this should be part of the offer and not replace what we already have. We know that technology works for some, it doesn't work for all, and that's both from a person point of view and also a condition point of view and a specialty point of view. And one benefit of the pandemic is that we have advanced at pace with innovation, which we need to build on as we move forward. So when we talk about next steps, finalising our GIFT deep dive action plan, focusing on our top 5 priorities with agreed delivery timeframes is what we need to do. We need to continually monitor, evaluate and re-evaluate, supported by GIFT and the partnership working with people who access the service, our colleagues, the community and the public and our charity organisations to support and shape our future state. Thank you. Any questions? Or are we taking them at the end? Sorry, Jeremy.
That's all right, Jen. We'll pick those up afterwards, if that's okay.
Thank you.
And last but not least, we'll move on to Ian's presentation.
So, good afternoon. I'm Ian Pomeroy, consultant neurologist and clinical lead for MS at the Walton Centre in Liverpool. So I'm grateful to the MS Academy for providing an opportunity to talk today and to share this work with you. Our working title is a practical example of regional service redevelopment, with the subtitle and a quote from mine that appeared in the report suggesting that COVID is an opportunity to restart services, so let's restart them better. I should point out, I think at this stage, to orientate you, this is very much an unfinished project, and I want to present it in that way. This is very practical. All I want to do is give you a very simple run through and presentation of what it is that we've done. So this work has multiple origins. So from a personal level, if you'll forgive me, so I'm part of the MS Academy, the MS Leaders Academy. This is an MS Academy initiative led by Gabriel DeLuca, Barbara Hose, and a diverse group of delegates within MS services around the country. So this is quite a useful opportunity to find some practical application to these new skills. Of course, this comes from part of the bigger project in MS Academy, Raising the Bar, and more specifically from the recent publication on NHS Reset and Reform. And of course, the third strand of this is the Optimum Care Pathway. So this is published by NHS England as part of a redesign of specialised commissioning. So I want to focus on that next. When I first saw this, or saw the first draft of this as, as MS Lead, I thought of this very much in the way that I had with previous publications, such as the NICE 2014 MS Management Guidance. And so, there are some similarities, certainly from the MS service. We are very much within the centre of this pathway. And I looked at, some of the things that we could change, things that are within our direct control and responsibility, and there are many of those. But as you look through, there are very clearly in this publication many other aspects that are outside of our own controlled specialist team, and clearly requires more coordination and communication. This is perhaps a little more complex than what we've had before. I think it's establishing what good care looks like. It's very much a two-dimensional route map rather than the previous nice list of guidance. So this is going to require a more complex implementation. And as part of that, we set up a regional workshop. So this is led by Sue Thomas, by Ruth Austin-Vincent, from the MS Society, from Julie Riley and myself from the Walton Centre. And we'd initially planned a regional meeting for the 18th of March 2020, which in retrospect was a disastrous date. And in order to avoid being our own regional super spreader event, we obviously had to postpone that, went through COVID, and as things were settling down in the autumn, we managed to get this reconvened online. So we set up quite a diverse delegate list. So there were 47 participants, including clinicians amongst all aspects of the MS team, but also our own Walton Centre integrated neurology nurses. These are nurses that are employed by the Walton Centre but are very much situated and coordinate with the community teams. The community teams themselves, psychology, managers and commissioners, charities, patients and carers. So I think we got quite a diverse mix. In retrospect, I would have liked perhaps more representation from primary care if I was doing this again, and moving forward. These are our stated aims, essentially a clearer understanding of what we currently have planned for local development, and then also to identify practical methods of implementation. And we'll go over the agenda in more detail in the next few slides. I'll show you what we did. So to go slightly out of order, we're very grateful to Matt Craner for speaking to us and sharing his experience in setting up a new MS service in Frimley. This was a sobering reminder of the amount of time, dedication, and particularly striking from Matt drive required to effect service change, but also some inspiration that this can be achieved. It's very clear that the challenge to the Walton Centre is quite different. We're an established large regional hub and spoke model, which is the model that predominates throughout the North Midlands of England. We already have an established and quite varied MDT. We have our own occupational therapists, physiotherapists, orthoptists. We have a variety of services, including things like specialised symptom management services. So we're starting very much from a different point. We were able to show some outcome measures measured against requirements of the service, which we're pleased with, including particularly proud of our outcome measures to show that we can make a clinically, so statistically and clinically significant difference to fatigue, for instance, in MS. So these are outcome measures specifically within the service, but it's very clear that optimum care pathway and our current discussions at the MS Academy go far beyond that. And that was illustrated in some of the other talks. So this is from Ruth Austin Vincent, who presented the findings from a variety of face-to-face structured workshops with MS patients and carers, representatives of the MS Society around England. Essentially, Ruth was able to tell us that the pathway was well received, but it was felt so well reviewed, but currently not being received. There was comments that current management has a focus, so it needs more of a focus on symptoms, not just DMTs. There were comments about service access, particularly for progressive MS, geographical variation, requirement for clear and consistent information, particularly regarding the time of diagnosis and treatment options. There were criticisms of lack of shared patient information involvement and also on access to therapies, OTs and physios. And we also had from Sue Thomas some local data on hospital admissions. It's apparent from that most of the admissions are due to deconditioning, not managing at home, often with a physical prompt or precipitant, at higher levels of disability rather than due to relapses. And there were comments made about lack of responsive support at home, and the issues of treatment of UTI were highlighted here. So following the talks to set out where we were and what we wanted, there were then some workshops. The delegates were split into 4 varied groups to answer these questions. So essentially, we had 3 simple focus questions. What do delegates think is important? What's currently being delivered well? And what do we need to target moving forward? So you're pretty much up to date now. This is where we've got to. We've recently published the meeting final report. And this is really our summary slide. So if you'll forgive me, this is paraphrased from the main report for illustrative purposes to fit on the slide today. And hopefully this is an illustration of the main conclusions. We got some good feedback on the current service and a strong steer about the priorities for development. So these themes that we mentioned: responsiveness, clarity and information, links between the MS service and the community, and more priority for emotional and psychological support and treatment. So to end with a positive note, this is some feedback from a focus group at the West Cheshire MS Society, who are keen to be involved moving forward. And then to leave you with a challenge. So Matt Craner was able to present, with the completion at least, so we say, of his chapter, but the book is never finished. So we're starting out again with this project. It's very much unfinished, and I've tried to present it as such. We're grateful for any feedback and advice, and I hope that sharing our experiences is some assistance to those undertaking a similar challenge. Thank you for your attention.
Thank you very much, speakers. That was fantastic. Thank you very much. We have 2 questions in the Q&A at the moment, and they're both quite challenging. So a 3rd question has popped up. So I'm gonna start with you, Georgina, if I may, with the first question from an anonymous observer. What are the key enablers to achieve a successful outcome in engaging with new systems?
Well, the key enablers. So one thing I would say is that leveraging data and evidence is going to be really, really important. And there are a number of opportunities to do that. So, for example, specialised commissioning at the moment are reviewing all of their processes and thinking about how they can support things like clinical reference groups to function better in the future with the right data and evidence. So that's a kind of clear opportunity for change. Similarly, DHSC are drafting a data and intelligence strategy at the moment, and there are good examples where of kind of data and evidence being used to kind of full effect. I think that we can perhaps try to kind of agitate that process a little bit. At a local level, what I'd say is that there's going to be a couple of things created through this legislation. So there's going to be ICS boards and there's going to be ICS health and care partnerships, both of which will have a duty to collaborate. So it's really important that we utilise that lever and remind them of that duty when it comes to pass. They'll also be assessed against things like their financial commitments as well. Things like joint strategic needs assessments aren't necessarily going to go away, so they remain a key kind of opportunity for change as well. I guess the other opportunity to say is that with certainly what I'm hearing from kind of the voluntary sector and from people with neurological conditions is that there's an awful lot of will and momentum for change, not least for in light of the significant disruption of COVID-19 on services. So although I guess many might be feeling exhausted, etc., actually the need to kind of collaborate around this stuff has never been more important, and we need to, and I think the will genuinely is there. Yeah, and the environment seems more right for us to be doing that as well.
Thank you. I'd like to come to you, Jen, please, if I may, on that similar sort of question about key stakeholders and change. So for the Raising the Bar for MS audit, we have interviewed around 50 to 60 MS teams around the country. And the most striking and common factor is the inability to achieve change locally. Now, what you've described as the operational manager is someone who implements change. I think most of us would say that they don't get change locally, despite efforts and recommendations and obvious service deficiencies. So what's your guidance in how to achieve change from your experience?
Thanks, Jeremy. I think it's extremely hard. I think it's extremely hard previous to COVID, but COVID has kind of set the cat amongst the pigeons in terms of kind of where we all are now. And as the ICSs and the boards and the partnerships are all being set up, I think one of the key things that we need to do is make sure that we've got good collaboration and engagement, and also we make ourselves heard and what our priorities are known. Obviously, the NHS is looking towards a recovery and restoration, and we know that will predominantly be around kind of the very urgent cancer-related priorities, orthopedics, ENTs, long waiters. So the focus very much, I assume, will be on reducing that kind of build up and backlog. And I think what's extremely important for us, which I know our trust as a board are keen to do, is work with the ICSs and make sure that just because we aren't reporting such similar numbers, or it's not kind of flagged as much from a neurological disorders and conditions point of view, it's imperative that we get the investment and the support to develop services, and we need to make sure that we've got the right people making that argument on our behalf.
Okay, can I come to you, Ian, please? And I think what you have highlighted at one level is a really important problem that we have. So you talked about Matt Craner's work at Frimley. And when I interviewed Matt for the Raising the Bar for MS audit, I heard for the first time about this work that they'd done, and I thought it was great. No one else knows about it. So how can we have a situation that shares practice, experiences, and successes?
It was a part of what we were being asked to do, and I suppose a part of what we picked out from the day in question as well. I mean, hopefully things like this would be part of that. sharing that experience, the work in raising the bar. I guess we've got to keep talking.
Okay, just as an aside, I think the reason Matt was successful is he got funded, and most of us don't get funded to service develop. So I do think that's a relevant issue. Georgina, I want to come back to you. You said there's an appetite for change. I think there's always been an appetite for change. What's the difference now?
Yes, there's been an appetite for change, but I don't necessarily think the levers for change have been as available. So I genuinely feel like certainly at a national level, more people are listening. The other thing is that if we think about some of the financial pressures that lots of these organizations are under, that's meaning that we absolutely have to collaborate far more effectively and efficiently than we have done in the past. It simply doesn't make sense to be to carry on in a fragmented way, and it's not a sustainable way of doing things. So I feel like kind of the combination of those factors mean people are thinking a little bit more innovatively about how we can address some of these challenges.
Ian, can I just come back to you a second? So the optimum pathway, and I was fortunate enough to be involved in that piece of work. Do you think it's deliverable?
Not in total, because I think it's quite aspirational. I think a lot of the points you sort of read it and you nod, don't you? I think a lot of the things we're being asked for, things that have been on the agenda for a while. I mean, it's not written in a way. It's not like the nice guidance, with 100 and whatever it was things to implement. It's more qualitative than that, isn't it? So I certainly think we can move much more towards it. I mean, to sort of address your question, the previous question rather as well, I think one driver that could make things different is, we've all been saying for years about integrated care, and here it is, it's explicitly set out. So I suppose going back to my last slide, I don't think it's something that'll ever be finished, but I definitely think it's the right direction, and I think there are some tools emerging that will allow us to push that way.
So just to pick up on the optimum pathway. So as part of the Raising the Bar for MS audit, we've anticipated or estimated that we're short of 150 MS neurologists in the UK. We're short of 300 MS nurses, short of 150 MS coordinators, and about a similar amount of MS specialist pharmacists. Those numbers are unachievable. What would you say should be the strategy to manage what is an increasingly complex, increasingly difficult, but only a small fraction on the hit list for people at higher levels in healthcare funding?
Well, you're asking what to prioritise.
I'm asking what you think we should do as a strategy to move forward.
Yes, we haven't quite got to there yet. I'm taking you to the update of where we've got to. We've identified the priorities. I guess we're now looking into the practicalities, and we are going to come across these sorts of limitations. In particular, we've already had feedback from the local MS Society, and we've already got a bit of attention. We've got people that want to move, and we want to take advantage of that and keep them on board, and that is the worry. We're trying to move this now at a time when we're coming out of COVID, I still have some members of my team, it's just passed, but who were under instruction, they weren't to have any non-vital meetings. It had to be directly related to clinical care here and now. So yes, we are going to need more resources there. Strategy, we've set out the priorities. We haven't yet got as far as looking at how to implement them, and I agree. I think we're going to come across some of these practical issues as we do.
Jen, can I come to you, please? One of the criticisms about GIRFT is that the data are inaccurate. and that the data are almost as inaccurate as HES data. What's your reflection on the accuracy of GIRF data locally, and how useful as an initiative do you think it's really been?
So I think thanks for the question. I think when you look at any data set, you always can pull inaccuracies from it. But I was very pleasantly surprised when I saw the data pack from GIRF. It was extremely detailed, and it allowed you to see the themes that were emerging. So yes, there will be issues and errors within the data set, but it was very clear when we looked at it that from an outpatient point of view, we were doing quite well. Definitely still room for improvement. As I say, we need to look at how we introduced procedure-based outpatients closer to the homes of people, so they're not having them to travel back and forth for a 5 to 10 minute appointment. But it was clear when you read the document and the data attached to it that the work that we need to prioritise is very much around our acute model and support to our wider colleagues in our partner hospitals. And that's certainly how the rapid access to neurology assessment service kind of started to develop, primarily by our consultant lead, Dr. Krishnan, who had always had the ambition of doing something like that, but the gift and the evidence and the support that gift give us allowed us to take that through to our executive teams and gain their support. So to answer your question, there are issues with data. There always is. It's never going to be perfect, but I was impressed with GIRF and what that allowed us to see, and the power that it gives us to then take that forward and implement some change. And I'm keen to continue building on that, especially with the rapid assessments, because as I say, the things that are emerging from that at the moment are extremely powerful.
I want to come back to Georgina, if I may. You showed early on in your presentation a slide about cost per head. Why? What are the explanations for the variance? Was the first question to you, or do we just know that there's variance?
That's a really, really interesting question. I think I'm not sure we quite know, to be honest with you. There are kind of different, I guess, policies and procedures at a local level about what's specialised, what's not. If you think about the neuroscience service specification, for example, that's been being reviewed, I think, at the moment, but that's been in the process of review for about 7 or 8 years, and isn't terribly clear about what should be commissioned where. It's also that we're largely place-based through that specification, which isn't terribly helpful. And actually, some of the reforms are looking at moving to a population-based model, which again kind of underpins the importance of getting our ducks in a row in terms of data and evidence. But I would expect that some of it may well be down to kind of local cultures and behaviours as well. So I'd say a mixture of factors, really.
So my second part to that question may be a bit more difficult, which is you talked about unwarranted variation. And we've seen this previously in people saying about unwarranted variation in, for instance, prescribing. How do you determine what's unwarranted?
Well, I think the optimum pathways actually are a good place to look at that in terms of, as a community, we're saying this is what good care ought to look and feel like. There are some aspects that you would expect to be non-negotiable as well. So things like, for example, in our patient experience survey, we asked people whether they received written information at diagnosis. That's pretty much set out in most NICE guidelines, to be honest with you, for most neurological conditions. And an awful lot of people came back to say they just didn't get that. A lot of good care would particularly in neurology, would also be about having a care coordinator or a first point of contact, or or care navigator. They're called lots of different names. But again, lots of people with neurological conditions report that they simply don't have that contact in place. So there are some things that you would expect there to be variation in. For example, treatments which may well people have different motivations, I suppose, for taking those, and will weigh up the risk and benefits of those quite differently according to their own individual circumstances. But there are other aspects of care that I think do feel kind of non-negotiable, to be honest with you.
Okay, there's a question here that is a great question from Sandra Bartholomew Pirez. With the creation of ICSs mandatory from next month, how is their work being evaluated, particularly for the multiple service providers linked with neurology? Is there a document setting out these outcomes? And do we have appropriate outcome measures? So I'm going to go around all three of you for that one and start with you, Georgina, because I think you probably perhaps thought about this a little bit more.
So if I start with so the only thing they've really set out, to be honest with you, in terms of the outcomes associated with these things are some of the financial parameters, and even that isn't terribly clear. There are, as I say, there will be a duty to collaborate, but in terms of how that manifests itself, etc., that's pretty open at the moment and won't become clear until we've got regulations and guidance through. In terms of outcomes measures, I don't think we have got a good set of them within neuro, and there's work going on through NNAG to try and define those on a neuroscience-wide basis, kind of recognizing perhaps that our strength will be if we work as a community rather than specific to condition. And I guess the need to get that work completed and to define what those outcome measures look like, and indeed what good experience looks like and how that could be measured is actually going to be really, really important. And if we don't do it, NHS England will do it for us, and we probably don't want that to happen.
Can I come to you on that, Jen, from a kind of local level in your work with the locality about the, as it were, essentially the accountability?
So it's an extremely good question. It's one that that people are asking across many different levels within many different organisations, and I think the answer is no. It's simply that we don't know how this is going to work, and we certainly don't know how it's going to be evaluated and how the outcome measures are going to be presented back. It's one of our real concerns within healthcare at the moment around how that does work, and the senior people within our organisations are kind of asking those questions. But it is a very short answer as no, we don't have the information that we need, and we need it quickly so that we can start to understand how then we play a part in it.
Okay, Ian, I'm going to give you a slightly different question actually, if that's okay. So this is from the floor, from John Woolmore in Birmingham. One of the biggest barriers to driving change locally is finance. Given we now have good data from GIRFT, do you think there will be a drive to properly redistribute resources according to population and population deprivation indices? Until this is done, there will remain striking inequalities to the disadvantage of certain regions or populations.
I don't think I can comment too strongly on that. I don't have any national involvement at this time, but I think it makes a good point, and we may have similar issues from here.
Short and sweet. It is unbelievably difficult, isn't it, all this issue? So Jola Matthews has asked, are there examples from other areas of medicine from which neurology and in particular MS can learn from? Or should MS be the exemplar for other long-term conditions and specialties? Georgina, you're covering a wide remit of neurological diseases. Do you think there are neurological diseases that are way ahead of us in this ilk?
Not necessarily. I think in MS there's a lot of really good stuff that's going on, not least for the work that you've done through the academy. I know the MS Trust, for example, are also revisiting their MS nurse work this year as well, which is going to be a really important piece of the puzzle in terms of making the case for improved services. That being said, more broadly, I'm always quite impressed by the Parkinson's Excellence Network and what they're able to achieve, and the audit and the way in which they involve people with Parkinson's throughout that process. It really is fantastic, and I think that's something we could all be learning from. And then, of course, there's things like this, like SNAP in stroke as well, which has undoubtedly helped to improve stroke care as well. So I don't think anybody's quite got the perfect model, but I certainly think there's areas that we can perhaps pick and choose from.
So last question. Well, we're coming up to, yes, we've got 2 minutes left. Last question. And I go around the room, and we're going to start with you, Ian. We're going to go to you, Jen, and then we're going to you, Georgina, last. One of the problems with reports and initiatives, etc., and we're talking a little bit about the NHS Reset and Reform report, is that they gather dust, and ultimately, actually, they have little influence. And one of the key outcomes from the College of Physicians' 3 MS audits was that they'd made no impact, or at least there had been no demonstrable change. How do we move from pathways, recommendations, etc., to actually delivering on change that leads to benefits in care? Ian.
I mean, you read the optimum care pathway, and I think, yeah, this looks all very, it looks very positive. I think it's a good direction of travel. I mean, that's what we're trying to do. That's why we've had a public, a very open, broad consultation. So I'm sure we will be held to account for that. So I think just having these meetings, speaking, will bring that around. I think we're going to be able to answer that question perhaps in more detail in the future. So where we've got to is we've set out, we've had a broad consultation, and we've now got a clear idea of what the priorities are. I think the next step, we need to be writing things that will have demonstrable, smart, as it were, outcomes, which we can use to drive this forward.
Jen, what would you add to that?
I think I agree. Lots of reports land on desks, and you're right, they sit there, and sometimes nothing much comes from them. I think what we need to do is be very aware that we need to do the right thing at the right time for the right person, and we need to evidence the quality of that and the benefit of that to the person receiving that care or support. But equally, we need to demonstrate and justify the evidence from a financial sustainability point of view, and quite often, by doing the right thing at the right time leads to, efficiencies. And I think we need to approach it from both sides, because finances within the NHS are extremely restricted, and we need to be going into those conversations around service development with open eyes, and justify a quality case and an improvement case for the person and the service, but also how's that financially sustainable, and how are those efficiencies going to fall out.
Thank you. Georgina?
I agree, obviously, with everything that's being said. I guess one thing that would be really good, perhaps, to come out of this is a pilot of one or more elements of the optimum pathway. Ideally, we'd like to do pilots of a number of the pathways that I mentioned as well, and that would also ideally allow us to kind of measure outcomes, I guess, common outcomes across multiple neurological conditions. So that'd be something quite practical that I'd like to see. And, as an alliance, we're here to kind of help perhaps work through that, if that would be an option.
Thank you. So we have run out of time. I'd like to thank the 3 speakers for their preparation and their presentations, and for trying to answer some really tricky questions that I think I've put to you. I'd also like to thank Roche for sponsoring the webinar, the Academy for hosting it. The link for the NHS Reset and Reform report is in the chat. It raises lots of questions. and we hope to provide some practical answers to that and practical solutions in the Raising the Bar for MS service and prescribing audit report, which will be circulated to the authors soon. Thank you for attending, and we hope this has been valuable for you, and we look forward to the next webinar. Thank you.